Hi, everybody. Thanks for joining us for Dr. Mascarenhas's presentation on optimizing care for anemia and myelofibrosis, in current practices and future innovations. This is going to be a great presentation, as always, from the illustrious Dr. Mascarenhas. This is a presentation produced by Plexus. Uh, and sponsored by the MPN Education Foundation, not to be confused with the Research Foundation. Many of you are familiar with the MPN Education Foundation from our production of every other year so-called Scottsdale conferences and our sponsorship of MPNet, the oldest online support group with archives going back to 1996. Facebook, try and match that. Um, and with that, I will turn you over to Dr. Mascarenhas because there's plenty to be discussed today. I do want to add, lastly, that Plexus has offered the MPN Education Foundation an honorarium for this production, and we have declined it, but we appreciate Plexus's generosity. Doctor.
All right. Thanks very much. Thanks for inviting me. I'm always thrilled to join for patient engagement, and special thanks to David and Joanne for proposing me to speak, and Plexus for putting this together. The talk is really focused, of course, on myelofibrosis and anemia specifically, but I'll try to broadly cover things. The focus is anemia. At the end, I'm happy to take questions if they're beyond anemia. But today we're really focusing on anemia. And what I'm hoping to do, and anyone who's seen me talk will recognize that sometimes my talks are a little ambitious, and perhaps comprehensive to the point where it may be challenging to get all the points in. So what I'm trying to really do is summarize what I think I'm trying to convey to the audience today, and I'm hoping that you will take away from, which is recognizing anemia is common in myelofibrosis. It usually progresses with myelofibrosis and contributes to prognostication, which I'll show you, and that it's really complex in nature. And this is the part that I think is really pivotal for not just the patient, but the physician to appreciate that it's not one thing that drives anemia. And I wish it was simple as iron is low, so if you take iron, it will improve. And I hope I can convey that in today's talk. And for that reason, it really needs the treatment and addressing myelofibrosis really does need to be individualized for the patient, because different mechanisms at different points in the disease with different treatments can require different considerations for addressing it. And that's what I'm really hoping to convey today, that it's not one approach fits all, and that patients really do benefit, not just symptomatically, but I think generally benefit if we address their anemia successfully. And then I'd like to just tantalize you with some new therapies that I really am excited by, that I do think will help patients that are dealing with anemia and myelofibrosis as we move forward. So first of all, anemia and myelofibrosis. I'm going to put it in perspective. Myelofibrosis, of course, is a malignancy of the stem cells in the bone marrow that make whites, reds, and platelets. So reds are the part that are involved with anemia, but you can have cytopenias, low blood counts, leukopenia, low white count, anemia, low red count, thrombocytopenia, low platelet count. So those are the terms that we're often using. Cytopenias meaning all of the blood counts being low. This is an inflammatory disease, so patients often feel unwell, often from cytokines, inflammatory markers, and symptoms can be varied: night sweats, fevers, weight loss, bone pain, what we call malaise, just not feeling well, and inactivity, unfortunately, becomes very significant. Some of those symptoms can be clearly linked to anemia, but some of them are not clearly just anemia. So I want to make sure the audience is considering that although patients can feel fatigued and weak and short of breath, things that we might say are classic anemia symptoms, they're also classic protein symptoms of the disease. Even when the anemia is corrected, patients can still feel unwell in those ways. So anemia is complex. It does lead to symptomatology, but not all the symptoms that are often labeled as anemia symptoms are fully related to the anemia. The disease itself is really a symptomatic disease because it's an inflammatory disease. And then, of course, everyone is aware that spleens can get big. Spleens sit in the left upper quadrant where this little organ is showing you here of the abdomen, below the ribs, right underneath the ribs. And that can cause discomfort, early satiety, getting full very easily, even issues with bowels and constipation or diarrhea. So the spleen is a organ that harbors a lot of the abnormal myelofibrosis cells and can get larger with disease course and often tracks with anemia. Bigger spleen, patients often will develop worsening anemia because much of the blood cells can get stuck in this web of a spleen. Anemia is probably seen in, at the time of diagnosis, almost 40% of patients. When I say anemia, I'm saying specifically a hemoglobin less than 10. And 20% of patients are already becoming transfusion requiring. I don't know about dependent, but requiring. So anemia often results in the need for red blood cell transfusions, and transfusion dependency is the need to continuously get transfusions. And all of this is driven in large part by a bone marrow that's corrupt. It's no longer allowing for or supporting normal blood cell development. And one of the characteristic findings in the bone marrow is scarring or fibrosis, hence the name myelofibrosis. So when you look in the bone marrow, you can actually see scar tissue, like what is called reticulin fibers and collagen fibers. And that's part of the disease process. That also worsens with time, and that also contributes in some way to the anemia that we see. So cytopenias, low blood counts, anemia, specifically low hemoglobin, and symptoms can be related to anemia, as we're going to see, but symptoms are also related to the systemic inflammatory disease part of of myelofibrosis. And fibrosis is one of the hallmarks in the bone marrow. I show you this slide just to convey that there are criteria that we're supposed to use no matter whether you're in the US, Asia, South America, wherever you may be. There are global criteria that are deliberated on by experts in hematopathology and hematology that involve features in the bone marrow, the presence of mutations that tell us that there's a clonal process, and excluding other diseases that can look like myelofibrosis. And one important, I guess, pearl from today is that not everything in the bone marrow that has fibrosis is myelofibrosis. There are other diseases that can occur, for example, other blood cancers or even infections like tuberculosis. Other things can occur in the bone marrow and end up in the bone marrow that can cause a reactive fibrosis. So you have to exclude those things as well. Make sure that the fibrosis is not explained by some other cause. And then I want to direct your attention down below to the minor criteria. And again, today's theme is anemia, and one of the minor criteria for the diagnosis is anemia. And because the disease is associated with anemia, and anemia is part and parcel of the disease and gets worse with time, but has also been recognized to be an independent prognostic marker. So here, what I'm showing you are three different prognostic models that we use in myelofibrosis. I would say we use them mostly for clinical trial purposes, maybe for making decisions about transplantation, but often they don't actually inform treatment for the individual patient, but they give us a general sense of where in the spectrum of the disease arc someone might sit. And what is the point of this slide, which I'm trying to highlight here, is that of the variables that have been determined to be independently prognostic, in myelofibrosis, anemia always comes out as one of those strong variables. Hence, it shows up in all of these. And here I'm just showing you three of probably 7 or 8 systems that have been created over the years for prognostication. But here, anemia is clearly a strong marker of disease severity, particularly in the DIPS, the Dynamic International Prognostic Scoring System. In fact, as these disease prognostication tools were refined, they even recognized that even beyond anemia, the need for red blood cell transfusions itself is a further adverse prognostic marker. So anemia is common, it's part and parcel of the disease, and it has prognostic implication. Here's a depiction of the fact that I would say that almost everyone with myelofibrosis is going to experience anemia at some point in their diagnosis, if not up front, over time. It's sort of inevitable. It's part of the disease process. And if you take a look and say, well, if you just look at anemia, the hemoglobin levels and anemia in a group of patients with myelofibrosis, as the Italians did in this study, and ask the question, does anemia itself influence, irrespective of everything else, does anemia influence outcome? You can see that just having anemia is very significantly tied to outcome. And I show this with a very strong caveat. I don't want anyone watching this video and listening to me think about themselves and think, oh, well, this anemia that is being shown isn't telling me what my survival is. That's not the point of this graph. Really, the point of this graph is that if you take a large group of patients and then just segregate them and these lines indicate each group of patients by how deep their anemia is, we can see that the worse the anemia, the worse the outcome in groups of patients, um, suggesting that the depth of anemia matters. And on the right, if you just segregate patients by whether they are transfusion dependent or independent, being transfusion dependent in this orange tells you that the outcome is worse than patients who are transfusion independent. These are called Kaplan-Meier curves. And what they help us get a sense of in groups of patients, but not individual patients, is generally speaking, how do variables influence outcome? And the point of this slide is that anemia is not just common, as I showed you before, but it also has prognostic significance. Therefore, addressing anemia is critical in myelofibrosis. And we know, and most patients probably already assume that there are certain symptoms we can tie into anemia: fatigue, weakness, shortness of breath, even dizziness. And that can affect, normal activities of daily living, taking walks with your spouse, or just being engaged and being mobile can clearly be impacted by anemia. And this obviously affects quality of life, and can have a very significant emotional and psychological impact on a patient if they are not feeling well enough or strong enough to participate in social activities, family life, work activities, and not knowing what tomorrow will bring in terms of their physicality and their strength and their sense of well-being is very significantly detrimental to sense of well-being and psychological impact. And I for sure definitely recognize that. And the reality is some patients are stuck needing transfusions, and that tightens their life around a transfusion center or even an ER sometimes. Again, increasing stress and the impact of having this disease. Anemia is very significant. We do have guidelines that help us guide physicians across the country and even actually across the world. People look at these National Comprehensive Cancer Network guidelines. And what I've pulled out from the guidelines is a version of the page for treating myelofibrosis anemia. So whether you're a doc in Idaho, in California, in New York, wherever it might be, you can refer to these guidelines, and they generally help you by providing consensus agreement amongst experts based on literature of how best to treat your patient's myelofibrosis-related anemia. So the first thing is you have to make sure that the patient does not have anemia for other reasons. And this is really critical. We often, myself included, are very focused on myelofibrosis and treating myelofibrosis and dealing with myelofibrosis. But patients with myelofibrosis are not just myelofibrosis. They can have a polyp or diverticuli that can bleed in their intestinal tract, or a small ulcer from stress that could bleed in their stomach. Or they could have deficiencies in B12 or folic acid or iron. They can have other reasons for anemia. So it's really paramount that the physician is thinking broadly, considering other competing reasons for anemia, and not just assuming it's myelofibrosis. The reality is it's often myelofibrosis, but you want to make sure that you can address the low-hanging fruit before moving strictly to a myelofibrosis-directed therapy. But what you can appreciate here is that if you have ongoing symptomatic spleen and or symptoms, so it's not just anemia, that there are other parts of this tripod of the disease, spleen, symptoms, anemia, then you really best suited for a JAK inhibitor? Because JAK inhibitors are more likely to address the spectrum of disease aspect, spleen, systemic symptoms, and anemia. And the preferred regimen by the NCCN guideline committee is momelotinib, which we'll talk about it, but also pacritinib could be an option. And then a concept of combination therapy, which I'm going to touch on. For example, ruxolitinib or Jakafi, our first and best in class JAK inhibitor, combining anemia directed therapies with Jakafi in order to improve the aspects of the disease. So we're going to go through this shortly, but I'm trying to give you a broad sense of how we think about anemia in the context of the other disease-related symptoms. And there are a number of options that we can use in this green box if patients have anemia and maybe just anemia. They're not really having fevers and night sweats and other systemic symptoms. Maybe they don't really have a big spleen, but they have more of the bone marrow failure part of the disease, and the anemia is prominent. And I see these patients, they may not really need a JAK inhibitor. So sometimes what we do is go to other drugs. So ESAs stand for erythropoiesis stimulating agents. These are agents that are basically mimics of growth factors that your body would normally make to stimulate red blood cell production from the bone marrow. And you can give these drugs, drugs like Procrit, Retacrit, Aranesp. These are drugs that are usually given subcutaneously to stimulate the bone marrow to work. The problem is they often don't work if your own hormone level, erythropoietin level, is already elevated. So it's important for a physician to check that EPO level to make sure that it helps guide this treatment decision. And we're going to talk about a drug called luspatercept or Reblozyl, which I'm personally excited by and I think is a nice addition to the armamentarium. And then there's some old drugs like danazol, which I'm not going to mention, which I used earlier in my career, but I would say are less frequently used today. And then again, pacritinib and momelotinib are the two JAK inhibitors that stand differently than the others like Jakafi and Inrebic in the sense that they have better data for anemia improvement. You'll notice something that I'm just gonna point out here. Whether you're looking at the red box for patients who have multiple MF-related issues and they need therapy, you'll see clinical trial is number one. If you look in the green box, clinical trial is number one. Even if you look at this blue box, clinical trial is number one. These are patients who are already on a JAK inhibitor but have developed anemia. So there's different aspects and different areas where anemia might emerge and one might want to address it. But in each aspect, the committee recognizes that clinical trials still remain the top choice if available and if the patient is interested. Clinical trials is always still important. And the reason why is because our armamentarium, although is growing, is still inadequate and still imperfect. And there's still room to grow and improve how we treat, well, in this case, anemia. Therefore, clinical trials always an option. JAK inhibitors are great drugs. I can say that very personally from being involved in the development of all four of these drugs, but also just from treating a lot of patients and recognizing the great benefit JAK inhibitors have provided our patients. And here, and when I say great benefit, I'm talking about improving spleens, improving symptoms, and I do believe that each of the JAK inhibitors, when given to a patient, is much more likely to improve even their survival than if they were not getting a JAK inhibitor. Because I think patients who feel better and who move and eat will always do patients better than patients who don't feel well and cannot move and are not eating. So JAK inhibitors definitely have improved our treatment armamentarium and our approach to patients, but they have historically not been great drugs for addressing anemia. And here in orange, I'm showing you ruxolitinib, that's Jakafi, and in green, fedratinib, that's Inrebic. And the point, and each one is a study, I should point out. So these are phase 3 studies. Comfort 1, Comfort 2, and Jump are big studies with Jakafi, Jakarta, Jakarta 2, and Freedom, big studies with Inrebic. And the point here is that the percentage of patients that develop anemia or continue to have anemia when getting these drugs still remains quite large. And these are the percentages of patients with anemia on these trials, suggesting that you really are not adequately addressing anemia. And the reason why is very simple, is these drugs are very good at what they do. They abrogate, they attenuate, they impair the signaling process that's driven by JAK2 STAT, the pathway that's activated in the blood cells because they're JAK inhibitors, and that's fundamental to making red blood cells. So if you do that, and these drugs do it really well, you will, on target, develop anemia. That's expected, actually. So the anemia here is not necessarily a shortcoming of these drugs. It's a validation that the drugs are doing what they're supposed to be doing. They're inhibiting that pathway. And inhibiting that pathway helps patients in other ways, but not anemia. So I would never criticize these two drugs for the fact that they don't address anemia, and there's anemia in these trials. They've done wonders for the field, but there's still more work to be done. And that's where we're going to go. There are, I would say recommendations from global consensus groups on how to work up anemia. And this is more for a physician than a patient. But what I'm trying to convey here is the point I made earlier, is that anemia is complex. So one needs to be quite thoughtful and comprehensive in understanding the mechanisms that drive the anemia. And this requires looking at different things like measuring the erythropoietin level, the hormone that stimulates the bone marrow, measuring things that mediate anemia like iron, B12, folic acid, even kidney function. Checking for bleeding is an important one. Checking the stool or urine, either doing a colonoscopy or gynecologic exam. Those are important ways of making sure that there's not alternative causes of anemia. And then sometimes patients can have things going on in their blood, processes that could lead to hemolysis, red blood cell production. So there are multiple tests that can be done to help physician understand and try to understand the nature of the anemia that the patient has. So what do we do about anemia? Well, in large part, to treat anemia, we're giving red cell transfusions, which are basically screened pools of red cells from donors, and they are matched to your red cells so that they're compatible, and then transfused in. So it's really a band-aid, an important band-aid, but it's not fixing the anemia. It's trying to get the hemoglobin up in order to address symptoms or stress on the heart that anemia could bring. ESAs, as I mentioned, erythropoiesis stimulating agents, those are hormones that can be packaged up into injections, and they can help stimulate the bone marrow to make red blood cells. Androgens like danazol are known to help anemia by mechanisms that are quite complex, but can also have symptoms, so they're not always grabbed off the shelf. Splenectomy, I would say, is rarely done today. Our institution has done a lot of splenectomies, mostly in the past. But if we don't have success with JAK inhibitors or can't give JAK inhibitors to a given individual, sometimes removing the spleen, particularly if it's big and bothersome, can actually help the hemoglobin and the platelet count go up. And then we've used a class of drugs called immunomodulatory drugs, or IMiDs, for almost 3 decades at this point. And those drugs, like thalidomide and lenalidomide and even pomalidomide, can also help anemia, but can also be associated with toxicity and side effects. And then we're going to talk about the JAK inhibitors. Broadly speaking, I would always give a range of about 20 to 30%. 20 to 30% in general for almost all of the studies, whether you're looking at immunomodulatory drugs, ESAs, androgens, it's about 20 to 30% of patients enjoy a benefit from an anemia perspective. So if you think about that, that means 3 out of the 10 patients you might treat will have that anemia benefit, but 7 won't. So these are clearly inadequate for the bulk of patients that we see. They benefit a fraction of the patient. So I would never discount these therapies because they could help individuals, but I recognize on a global level, there's still a lot of work to be done to improve our approach to anemia. So what factors do you even consider when making a treatment selection? Well, what is the hemoglobin level at the time of initiation of therapy? If it's low, some physicians might go for momelotinib if the patient has spleen and symptoms, as opposed to ruxolitinib or Jakafi. If they don't have cytopenias, some physicians might say, well, I'm going to start with the first class of drug, the first drug in the class, Jakafi, or maybe even fedratinib, which has been studied up front. If patients have low platelets, the drug of choice tends to be pacritinib or Vonjo, which is where it's been studied the most and has shown very nice data. And then how's the patient feeling? Are they afflicted by MF-related symptoms? Will that drive treatment selection? Or are there certain things that we want to avoid from a toxicity profile? So, for example, one of the toxicities, albeit very unusual and very easy to deal with, is something called Wernicke's encephalopathy. It's a vitamin B1 or thiamine deficiency that has been shown with fedratinib and Rebic. So that's easy to deal with. You just give someone a vitamin B complex and you can deal with it. But if someone were to have underlying issues with absorption in their intestinal tract or have already other neurologic diseases, this may not be the best choice. So we do have to consider the toxicity profile of the drug that we're thinking about, the context in which the patient is dealing with their myelofibrosis, and the goals of therapy when selecting our treatments. So I'm going to get right into this. This is momelotinib or Ojara. This is a JAK1/2 inhibitor. So this is called a kinome profile. And what it's showing you is different enzymes. So JAK1, JAK2, JAK3, TYK2, ACVR1, IRAK1, and FLT3. They're all enzymes. And each row is a drug. Jakafi, Inrebic, Vonjo, and Ojara. And what these numbers show you is, and here, the smaller the number, the more potent, is the potency in which these drugs affect these enzymes. So, for example, momelotinib hits both JAK1 and JAK2 almost equipotent, very similar to Jakafi, a JAK1/2 inhibitor. Whereas there's a difference here. Look at pacritinib. Pacritinib 6, which means you don't need much drug to affect JAK2, but you need a lot of drug to affect JAK1, means it basically spares JAK1. So you might be thinking, so what? Why do I care? And the reason why I think it's important to maybe appreciate what I'm trying to say here is not so much to memorize that Vonjo spares JAK1, but to realize that not all of these drugs are created equal. There's definitely differences in the mechanisms and to the degree that they inhibit certain enzymes that likely explains A, why they can be used in different niches, patient niches, and B, why they might have different toxicity profiles. So, for example, FLT3 is an enzyme that's present in blood cells. If you inhibit FLT3 for reasons I don't know why, and I've never met anyone who does, you will see the potential for more nausea and diarrhea with a drug. So if you scan this, you'll see, well, for pacritinib here, 14.8, fedratinib 15, they're inhibiting this enzyme, whereas momelotinib to much lesser degree, and Jakafi doesn't at all really. So we might expect more GI symptoms with fedratinib and pacritinib because of its mechanism of action. And that's exactly correct. Every study shows us there's more potential for GI toxicity. It's not guaranteed, and it doesn't mean that it's not tolerable, but it's more likely to occur with those two drugs. And because here, ACVR1, we see that pacritinib and momelotinib inhibit that enzyme. That is probably the reason why, or we think it's the reason why you get better anemia responses with pacritinib and momelotinib. So again, not to memorize these funny looking abbreviations, JAK1, JAK2, these are all just enzymes. The point of the slide is that all of these drugs have varying effects on different enzymes, which means the net result of each drug can be different. Even though from the same class, there are these nuances and differences that might explain toxicity differences, but also efficacy differences. And since today's theme is anemia, what I'm getting at here is this ACVR1 is different when looking at Vonjo, pacritinib, and Ojara momelotinib. So let's take a look based on that. So the study of interest is a study called Momentum. This was a relatively recent study, actually, that was conducted in patients who had already been on a previous JAK inhibitor. They had symptoms. That's what the TSS tells us. They were anemic, importantly, hemoglobin less than 10, and they had to have at least a 25,000 platelet or higher. And they got randomized 2-to-1, so you were more likely to get the momelotinib than the control arm, which was danazol, this historic synthetic androgen. And the endpoints are listed down below. And I summarize them just for simplicity's sake. What the study showed us was that if you took patients who had already been on a JAK inhibitor and needed to switch JAK inhibitors, and you gave them momelotinib versus danazol, and this was double-blinded, so patients and physicians didn't know, so it was really quite strict. You do see that momelotinib won, Ojara won on each account. It was better for controlling symptoms, 25% versus 9%. And again, for anemia purposes, it was less associated with less anemia. 30% of patients, in fact, had transfusion independence at week 24 compared to 20% of patients with danazol. So it was a friendlier drug for those patients who were dealing with anemia than historically we would expect with other JAK inhibitors. And it also was better for spleen, different ways of looking at the symptom score. And in every way, momelotinib was outshining danazol, which I have to say was not unexpected. That was expected. And the trial nicely showed that in a prospective fashion. But what's really interesting is sometimes the devil's in the details. So if you look at this, again, this is called the Kaplan-Meier curve. It's looking at survival on this axis, the y-axis, and on the x-axis time. And these two curves tell us what happens to patients over time in terms of survival. And what you can see is there's a difference here at 24 weeks between the momelotinib arm in orange and the danazol arm in blue. It suggests that if you get this JAK inhibitor, you were more likely at a shorter interval, because 6 months, 24 weeks, 6 months, kind of short, to have a better chance of survival than if you didn't get a JAK inhibitor. In this case, it was momelotinib. And there are other data sets that would suggest that that benefit might even be tied into improving anemia. That anemia, as I told you, is frequent and adverse prognostic marker, that improving anemia would then reverse the negativity and bring you into positivity, improving outcome. Now, someone in the audience might say, hey, John, why do these curves touch each other then after you keep following the patients? And the reason is because of crossover. So patients who were on danazol were then able to cross over to orange to the momelotinib group patients, and that's why the two arms end up crossing. So the initial difference in survival would be lost over time because then everyone was getting momelotinib. And here I'm trying to make the point that I jumped to earlier, which is that if you had a hemoglobin that got above 10 at week 24 with momelotinib, it did look like you had a better survival than patients who didn't. So effectively addressing anemia with this drug, momelotinib, improved the outcome. If you look here, these are median survivals. It wasn't reached in patients who had an anemia response versus patients who did not, where the median survival was about 38 months. So improving anemia with a JAK inhibitor, in this case momelotinib, was improving outcomes of our patients. So I want to get to pacritinib or Vonjo. Again, it's a JAK2 inhibitor like the rest of them, but it spares JAK1, and it also potently hits this ACVR1. And I'm going to get to why I think that matters. So there were two big trials that evaluated this JAK inhibitor, Vonjo. The PERSIST-2 was the more pivotal trial. These were patients who already had low blood counts. These were patients who would not have made it on to the comfort studies for Jakafi when we treated those patients many years ago. And these patients had low blood counts by definition, and they could have seen a JAK inhibitor. 50% of them had already been on ruxolitinib. And they got randomized to two different doses of Vonjo, 400 once a day, 200 twice daily, or BAT, best available therapy. And it was up to the investigator what treatment they gave the patient. And about half the patients half the physicians put the patients on Jakafi. And what did we see in this study? Well, we saw that, well, I'm jumping ahead, but what we saw was that the spleen and symptoms were better at 200 milligrams twice daily with Vonjo than best available therapy. But we also saw that there was an improvement in anemia. And we had not really seen this previously with, again, Jakafi and Rebec, and we were seeing it with Ojara. But here you're seeing that about almost 38% of patients in orange who got pacritinib, Vonjo, 200 milligrams twice daily, had an anemia response. In this case, transfusion independence, meaning that for 12 weeks they didn't need a red blood cell transfusion. Whereas it was much lower in blue in the BAT arm. Even in green, in the patients in the BAT arm, the control arm, who got growth factors, Vonjo was still better at leading to transfusion independence. And no matter how you looked at it, whether the patients, you took them and said, well, what about the patients who never got a JAK inhibitor before? Was that finding of the anemia particular to Vonjo? And the answer is yes. If their platelets were less than 50,000, still Vonjo. If their JAK2 mutation level was less than 50%, still Vonjo. Greater than 50%, still Vonjo. Meaning that even if you sliced and diced the patients and looked at different variables, that this drug, Vonjo, in these patients with low platelets was associated with a better anemia response than best available therapy. And like the momelotinib data, there was also a sense that the patients who got Vonjo in orange compared to BAT in blue were more likely to have this anemia response associated with ultimately a better survival. And that's, to me, not very surprising because anemia is a prognostic marker. It's an aspect of the disease. If you can adequately address it, then likely the patient is not simply going to enjoy that immediate benefit of not needing transfusions and feeling better, but can also enjoy a greater benefit of survival improvement. So where are we going these days? So here's a drug that I think is very cool and very likely to be of benefit to patients called luspatercept or Reblozyl. This is an injection. Unlike ESAs, erythropoiesis stimulating agents, this I would call an erythropoiesis maturation agent, EMA. And it works by binding. It's a trap. It's like an antibody. It's like something that this traps this ligand. A ligand is a molecule that tries to engage a receptor. And what it does is it takes a very specific type of ligand out of circulation. And this ligand, this cartoon is supposed to depict it, interacts with this activin receptor. And you might remember I was pointing out ACVR1 is it's one type of activin receptor. And what happens is with this luspatercept, you start to remove repression. So it's a double negative. You remove repression of red blood cell maturation, which means that you let red blood cells mature. And part of the problem in myelofibrosis, as we recognize, is that there's a problem in this final process of maturing red cells. So they took this drug and they gave it subcutaneously every 3 weeks to patients, whether they were not on Jakafi or they were on Jakafi. This way, looking on from left to right, whether they were not receiving red cells or receiving red cells. The point of this complex study of myelofibrosis patients receiving this EMA, luspatercept, is that you can see that patients enjoyed responses in terms of anemia improvement, which was most prominent in patients in cohort 3B, those that were receiving Jakafi and were needing red cell transfusions. So they had probably the best response from a transfusion independence perspective, with almost 30% transfusion independence. And then on the right, at least the patients who were getting transfusions had at least a 50% reduction. 50% of patients had a 50% reduction in that transfusion burden. And that led to the independence study. And the only thing I'm going to say here, because I don't want to jump the gun, this will be released in its entirety in about a month at one of our meetings. This was a pivotal phase 3 study documenting that luspatercept improved transfusion independence over 12 weeks, 16 weeks, and improved hemoglobins in patients with myelofibrosis. If you hear it was a negative story, don't believe the hype. You got to look at the details. You'll start to see the details later this summer. I use this drug frequently. I really think it's quite helpful for patients with myelofibrosis and anemia. Like usual, I'm talking way beyond I should have. So I'm gonna skip a couple of these slides just because I want to make sure I get to some of the juicy stuff. So here is a a concept of what's called BET inhibition. So BETs are proteins that help regulate the expression of genes. And we know from studies in the lab that these BET proteins are important targets in myelofibrosis and addressing anemia. So there's a drug called pelabresib, which has been shown in preclinical models to improve disease aspects of myelofibrosis, so symptoms, spleen, and even anemia by binding these BET proteins and affecting gene expression. And we took this drug after a phase 2 study into a phase 3 study and compared it to patients who received Jakafi plus placebo versus Jakafi plus pelabresib. And these were in patients with myelofibrosis who had not seen a JAK inhibitor before. So this was JAK inhibitor naive patients. And what we saw was that the patients had greater spleen reductions. This I'm showing you is 48 weeks. We even have 96 weeks data now. So 57% versus 37% of patients had a spleen response of 35% or greater, which is a regulatory endpoint. And you can see on the right, the durability of the spleen response was better in orange than in blue in the control arm, which is Jakafi. And the symptoms were better, nominally better, not statistically significantly better, but nominally better. You reduce the symptom burden by a mean change of 16 points with the combination of pelabresib and Jakafi versus 14 points with just Jakafi alone. And each symptom, itching, pain under the ribs, bone pain, whatever it might be, got better when you gave the combination. So it got more spleen reduction, better symptom improvement, and for the point of today's talk, we also saw improvements in anemia. And I'm just going to ask you to look at this mean hemoglobin curve on the right in orange, Pella and Rux in blue, placebo and Rux. And what you can see is that at every time point, patients who were receiving the combination of these two drugs had a better hemoglobin. The mean hemoglobin was higher. So we had better anemia responses when adding this drug. So that's a drug that continues to be followed out and evaluated in clinical trials. It's not yet available, but might be a good addition to the armamentarium as a combination partner. This is a drug called KER-050, now known as elritercept. Also, the same concept of trapping ligands, what are called activin ligands that are important for red cell, and in this case, maybe even platelet production and bone mineralization. So this drug might be a little bit more comprehensive than the luspatercept. And our colleagues in Europe did a study called the RESTORE study, where they were looking at giving this subcutaneous injection to patients with anemia, whether they were monotherapy after failing a JAK inhibitor or while they were still receiving a JAK inhibitor. And the point of this slide is to just, is just to highlight that even with this drug, we saw anemia responses at different levels of this drug. We're seeing that patients can have improvements in their anemia. And what I'm not showing you is we even saw improvements in their spleen, symptom, and platelet count, We really don't have drugs that improve platelet count. So this was kind of an interesting drug that's still being evaluated. You'll hear a lot about hepcidin. Hepcidin is the master regulator of iron metabolism. It controls whether you can absorb iron or release iron for red cell production, and therefore is a target in myelofibrosis. It is very high in myelofibrosis. It's overexpressed as an inflammatory marker. So DISC-0974 is an antibody that targets ultimately the production of hepcidin. And there are multiple drugs actually now that are trying to mediate aspects of this hepcidin production, trying to reduce it in order to free up iron for red blood cell production. And I just summarized here this study that's ongoing, mostly driven by our colleagues at Mayo Clinic, showing that this drug, DISC-0974, also parenterally given, was both safe and well tolerated and did hit its target. It reduced hepcidin and improved iron availability for red cell production and improved anemia and reduced transfusion dependence in patients. And some of the patients really had very nice responses. 50% had improvements of 1.5 grams per deciliter or greater. 70% had transfusion independence for 16 weeks, and 67% had transfusion dependent if they had a lot of transfusions, or at least a 50% reduction in transfusion burden. So this drug also, I think, might be an interesting drug. I will finish up with a drug called imetelstat, which is a telomerase inhibitor. It's an infusion that attacks this enzyme that's important for maintaining malignant stem cells. And we evaluated this infusional agent in actually, this was a phase 2 randomized study at different dose levels. And what we saw here was not only did it seem to improve survival in this randomized study, but it also was associated with an improvement of 25% of patients gaining transfusion independence. So suggesting that there are multiple mechanisms in which one can improve anemia. And that is encouraging because I think that we need different drugs for different folks. So in conclusion, anemia in myelofibrosis is complex. The management needs to be tailored accordingly to the patient. Treatment selection for anemia in MF should really be guided by the etiology, like what's driving that anemia. What are the baseline cytopenias might dictate whether you use Vonjo or Ojara or Jakafi. We do have these two drugs now that might be better suited for patients who have cytopenias like pacritinib and momelotinib. And we're really moving into an era of combination therapy, which is where I think we will definitely end up, which is can we combine these JAK inhibitors with novel agents that address the spectrum of issues, including anemia and myelofibrosis? And then we have these really anemia-directed therapies that look exciting, like elritercept and DISC 0974. Not ready for prime time, but getting there. Probably the drug furthest along that's already approved in MDS that has data in myelofibrosis is luspatercept or Reblozyl. So there are things to be done with myelofibrosis and anemia, but they have to be done carefully and thoughtfully. So thank you for your attention.
That was a fantastic talk. Thank you so much, Dr. Mascarenhas.
Okay.
We have a few questions from the audience, and I just want to one housekeeping item for those of us who don't look at these types of graphs all the time. When you say something like it's a 33-month survival benefit, does that mean until the patient is no longer with us, or is they left the study, or how did that work?
So it's a great question. So one needs to be careful when looking at these outcomes because exactly what you're pointing out, Joanne, is the case, is that when we look at Kaplan-Meier curves and we talk about survival within the context of clinical trials, we often will say, if we know someone has passed away for any reason, it may not even be from myelofibrosis, that's considered an event that then calculates into survival. But also, patients will come off studies and not be followed. They'll go back to their hematologist, maybe in a different town, whatever it might be. They can't be followed. Those are called censored patients. So that we count them as though they're not with us anymore, but we don't actually know that. So you always have to be very, very careful. There's two things I would say to a patient listening to this. Be very careful if any physician ever pulls out a scoring system and says, "Oh, look, you fall here 33 months," that does not apply to you. That just is a general, like when we look at patients and there's so many variables that fit in there, generally speaking, the median or mean is 33 months. That it does not tell a patient what to expect. So be very careful to not overinterpret or overthink that number.
Great, thank you. Back at the beginning of the talk, you talked about like the personalized treatment options, right? As we are becoming more accustomed to getting genetic mutation panels, et cetera. At what point do you think that we will get to a place where we can make those decisions based on our current mutations? And and part two of the question would be like, do you approach a CALR patient different from a JAK2 patient? Do you approach a post PV patient different than a post ET patient or a primary myelofibrosis?
The answer is yes, but not really. So we often will characterize patients by their driver mutation, by their risk score, maybe by other mutations they might have. And sometimes that helps in deciding whether someone's risk associated with the disease would warrant, for example, a transplant consideration rather than not pursuing a transplant, or even making a decision about timing and sequencing of therapies. But it rarely actually informs the therapy itself yet in 2026. But I do think that that's changing. So, for example, with the advent and the realization that mutant CALR protein is aberrantly expressed on the surface of the cells, then one recognizes that that might be targetable by immune mechanisms like antibodies. So now we have therapies in clinical trials that have looked very, I would say, exciting and potentially game-changing for some patients who have a mutant CALR disease because you can target it with antibodies or what are called BiTEs, bispecific T-cell engagers. So I think some CALR patients may have a very nice alternative option because their disease is slightly different of immune-mediated mechanisms or treatments. There are JAK inhibitors that are out that are selected for JAK2 V617F, and they're in clinical testing. That could provide a whole avenue where maybe you are taking the JAK2 mutated patients and you're treating them with a very specific selective inhibitor. We do have a sense that mutations to some degrees may influence, responses to Jakafi, for example. There's data would suggest that patients who have a very high JAK2 allele burden are preferentially going to respond the best to Jakafi versus patients who have a low JAK2 allele burden might work better with drugs like Vonjo. Having said that, in clinical practice, we don't really treat the patient based on those variables. We recognize that they may inform and challenge our expectations, but we don't select therapy yet based on that. I think as our understanding of the molecular mechanisms evolves, we will see therapies that are much more defined for mutations, but it's not yet prime time.
Great, thanks. Do you, so I started with this disease over 25 years ago, and there was very a few options, right, for treating the disease. Do you find it, do you, are you happy that you have all of these choices now, or does it make it more complicated to treat patients because there are so many?
I think it's both. I mean, I entered this field when there weren't any JAK inhibitors, so we mostly use hydroxyurea. So it is, for me, it's been personally super exciting and rewarding to see all of these therapies evolve. Some of them have not made it because they've been determined to not be sufficiently beneficial or maybe even toxic. So we've seen things crash and burn. But to see four JAK inhibitors allow us to tailor therapy, for different niches of patients, whether it's low blood counts, or other aspects of the disease, I think is a step in the right direction. So it definitely makes me happy to see that we have treatments, and I think those treatments improve not just spleen and symptom, which is not unimportant, but I do think they're improving the lives, quality and quantity of our lives already of our patients. But obviously it's not complete. We're building off of that, trying to let the science drive, the next wave of innovation to help our patients. But it does add a level of complexity, like you pointed out. One has to be more aware of and appreciative of the differences. It's really myelofibrosis is a word that is supposed to, take into consideration lots of different variations on that for different types of patients, whether it's an ET patient or PV patient that developed myelofibrosis, whether it's a patient who has a JAK2 mutation, a CALR, a MIPL, or triple negative. And each patient looks and feels differently, and their course can be quite different. So you really need to have a very good sense of the disease, the biology, the differences in the treatments. So there is a complexity that didn't exist before. It was simpler in those days. It wasn't as rewarding, but it was simpler. And now we have a more complex understanding that's led to more options. And we will see more options. I'm convinced of it. The next 3 to 5 years, we're going to have other drugs that are going to make it ultimately to the finish line that will help us treat our patients and individualize, but it will add complexity to those decision making.
Right. That's it is as a patient, it is an exciting time, and we do appreciate that there are more options for all of us. But we still do see patients that become frequent transfusion or become dependent on transfusion. And I'm just wondering, are there any specific complications that need to be managed with transfusions, or is it just a matter of inconvenience and time consumption for the patients?
Well, it's definitely an inconvenience, and it consumes time for the patient and often the patient's loved ones. There is a consequence of iron overload. So when you get a lot of transfusions, and typically we use 20 as the number, over 20 transfusions, you've added a certain amount of iron to your body that's hard for the body to get rid of. So it's not clear to what extent that iron overload actually causes problems to patients, but in related diseases like myelodysplastic syndrome, there is data that too much iron sitting in the bone marrow that's not utilized appropriately or in the liver or in the heart can impair the functioning of those organs over time. So there's a detriment to transfusions from iron overload that likely affects patients to varying degrees. It is very unusual to see an infection from a transfusion in 2026. Back before these products were known to be, screened and how to screen for them, that was a concern. But from the mid 80s on, I rarely see a transfusion related infection. But some patients can develop transfusion related reactions, immune reactions, in which after seeing transfusions, they could react from antibodies or other ways, and patients can have reactions to transfusions. So there are considerations to transfusions that go beyond the patient inconvenience.
Thank you. I think we're getting towards the end, but we do have a patient who's asking a question about a potential treatment being studied in Europe that might control fibrosis and anemia. And I was wondering if you might be aware of what that might be.
I don't know which drug the participant is specifically talking about. There are a number of different drugs we've evaluated multiple drugs that are anti-fibrotic drugs, with the idea that if you can regress the fibrosis, the scarring, maybe you could allow for better utilization of the bone marrow and production of blood cells. I have to say that has not panned out very well, in the sense like most of the studies that we've done have not actually shown that if you can induce regression of fibrosis, the anemia will get better. So unfortunately, I think it's a little bit more complicated than that. There are some therapies, and again, not knowing which therapy specifically the person is talking about, there are some therapies that are emerging, not specifically in Europe, although some of them start in Europe and then end up globally, and some of them start in the US and end up globally, that are directed towards the inflammatory process that governs not just the fibrosis, but also the anemia. The anemia can also be a consequence of inflammation. So hepcidin, for example, is a consequence of inflammation that can affect hemoglobin production. And maybe the person is talking about a drug called tesquinamod. Tesquinamod is a really interesting agent. It's been evaluated in different fields like prostate cancer and other diseases. And it targets something called alarmins, which are inflammatory markers. And by doing so, it reduces inflammatory cascade signaling. And with that, we have the potential to improve not just anemia and fibrosis, but just the way the disease cells are able to survive in the bone marrow, leading to hopefully more death of those cells. So it's a really interesting molecule, and the pathway is really interesting, that's being evaluated in clinical trials.
Okay. I appreciate you addressing that. Thank you. I think we're about out of questions, and I think that we should thank you and let you get back to your weekend. So thank you again for spending time with us.
Yeah, more than happy, more than happy. Really appreciate the invitation, and I'm always happy to answer questions if appropriate. You can share my contact information if I can answer a question about anemia or anything else. I'm happy to do so.
Okay. Thank you so much. Thank you,
Thanks.
everyone.
Thank you, Doctor.
Thanks, David. Bye.
And I guess that closes out our presentation. Ron, I don't know when you're going to close us out for real.
We will close out right now. Wanted to thank you both for your participation, as well as those still here. For those still on, just as a reminder, you will be sent an email with an evaluation tomorrow. We invite you to fill it out, and we encourage your feedback. And again, we thank you for your participation. David and Joanne, thank you both very much, and we will talk soon.
Thank you,
Thanks,
everybody.
Ron.
Thanks. Bye-bye.